Today we'll be discussing about atrial fibrillation and ablation, radiofrequency ablation. Atrial fibrillation affects approximately 2.4 million Americans. The most common symptom of atrial fibrillation is generalized fatigue. In addition to this, they complain about palpitations, lightheadedness at times, dizziness, and a symptom of irregular beating or some form of pressure in the chest when they are in atrial fibrillation. There are three types or three forms of stages of atrial fibrillation. One is paroxysmal atrial fibrillation, and that is when the patient has atrial fibrillation, it comes and it goes on its own. Usually this happens when they're younger, or it can happen during their middle age. However, as they get older, and if they've been having paroxysmal atrial fibrillation, and since atrial fibrillation can beget atrial fibrillation, meaning the longer they've been in atrial fibrillation and the more episodes of atrial fibrillation they've had, then they may become in persistent atrial fibrillator or persistent atrial fibrillation. What that means is they're in atrial fibrillation. However, instead of the atrial fibrillation stopping on its own, what ends up happening is they would have to require either medical therapy or a cardioversion from a physician in order to convert the atrial fibrillation back to normal rhythm or sinus rhythm. If this fails, or if they don't have any form of intervention or medical therapy, the atrial fibrillation can become chronic. And as time proceeds, what ends up happening is the left atrium starts to dilate, and the longer they're in AFib, and that means that they're in continuous or chronic atrial fibrillation. They're always in atrial fibrillation. The problem with atrial fibrillation is that it can lead to a stroke, thromboembolic stroke, which can be life-threatening in regards to the fact that you don't die from atrial fibrillation. However, you are debilitated from the stroke itself. So in order to prevent the thromboembolic phenomenon, the most important thing an individual can do is to see a physician in order to be on blood thinners such as Coumadin or other blood thinners such as Pradaxa, which was just approved by the FDA for atrial fibrillation, specifically in paroxysmal atrial fibrillators or persistent atrial fibrillators, with certain conditions that this medication cannot be given to certain individuals. However, Coumadin is a choice that's been provided to the majority of the patients. One thing I should say about Coumadin therapy is that the Coumadin level, which is called the INR, international ratio, needs to be checked periodically in order to make sure that the blood is not so thin or the blood is not so thick, in order to prevent either bleeding from a very thin blood or not having the effect of being on anticoagulation therapy if the blood is not thin enough. Therefore, the INR should be in a therapeutic range, and your physician can guide you with this. In regards to procedures, we have something called a pulmonary vein isolation or an atrial fibrillation ablation. This was discovered in 1998, and ever since then, our technology has improved so dramatically that we're able to perform these procedures now in approximately 3 hours. And it's an outpatient procedure. The patient stays in the hospital overnight for observation only, not specifically for inpatient purposes, and the patient is discharged home the next day. In addition to this, the patient will continue some antiarrhythmic medications for only a few months, along with anticoagulation for only a few months, to assure that the patient does not have any complications such as a stroke or have a recurrence of atrial fibrillation immediately after the procedure. In regards to the procedure itself, what we do is the following. The patient presents to the hospital, and if this is the cardiac anatomy, this is the left ventricle, this is the left atrium, and this is the right atrium, and this is the right ventricle, what we do is we basically bring in a catheter from the neck and advance it into the coronary sinus, which is located technically behind the heart, for which this has prongs on the coronary sinus catheter in order to pick up electrical signals from the left atrium and also some signals from the left ventricle depending on how it's positioned. In addition to this, what we do is we bring a catheter from here and place it up here, and this is a intracardiac ultrasound catheter. And this basically gives us a window in order to look at the foramen, which is basically the opening of the inner atrial septum. What we do is then, once we visualize this, we bring two catheters and advance it through here by doing a transeptal puncture under guidance with fluoroscopy as well as intracardiac echocardiogram with this imaging here, and then another one as well. Following this, what we do is we basically find the electrical signals around the pulmonary veins, and usually people have 4 pulmonary veins, but in some individuals the pulmonary veins are various in number or shape or size. And what we do is we then bring a catheter that has a circular prong on it, and we place it against the pulmonary vein antrum, which means the opening between the vein as well as the atrium. Following this, we pick up electrical signals from here and we record these. Once we see these electrical signals which are not normal or not supposed to be there, then we bring another catheter and we basically ablate around the pulmonary veins, not in the pulmonary veins, around the pulmonary veins, in order to electrically isolate the pulmonary veins. A lot of times what we do is we basically isolate the pulmonary veins in a wide angle like this, or sometimes we also separate them individually depending on the patient's condition and the size of the pulmonary vein. Once these pulmonary veins are isolated, then full testing is again performed prior to and after to in order to know which pulmonary vein is firing by giving the patient isopril, which is a adrenaline-like medicine intravenously in order to stimulate the heart to form or to get into atrial fibrillation again. If after multiple inductions or attempts to induce the arrhythmia, the patient is not inducible into atrial fibrillation again, then we're done and these catheters are removed from the body and the patient goes to recovery after the patient's awake from anesthesia. A lot of times we use general anesthesia to prevent any form of movement during these procedures. However, we have done procedures where the patient does not like any anesthesia or is intolerant to anesthesia, and we perform these procedures under conscious sedation. That means that the patient is deeply sedated, however, he or she is breathing on their own and is not under general anesthesia. Sometimes in some individuals the patient may also have an atrial flutter, and the flutter may be on the left side or the flutter may be on the right side. If the patient has a flutter, then what we would do is the flutter circuit usually goes in a circular manner, specifically if it's in the right atrium, and it could be anywhere in the left atrium. Most common flutter is usually in the right atrium, and what we do then is we bring a catheter and we break the flutter circuit in order to prevent the electricity from entering in a circuit either in this direction or in this direction. Therefore, the flutter is now completely ablated as well. Once this is completed, again the catheters are removed and the patient is discharged home the next day with certain medications that he or she will be given, and will follow up with us in approximately 7 to 10 days for an electrocardiogram, and continuous monitoring will be performed in 3 months along with episodic electrocardiograms to make sure that the patient is in sinus rhythm. One thing I'd like to say is that a lot of times atrial fibrillation may not cause symptoms, and this is important because in patients who have no symptoms they may end up with a stroke, and that is one debilitating factor that can be avoided if someone is checking their pulse regularly, as an example, or they don't disregard atrial fibrillation. So once they disregard atrial fibrillation and they're not feeling it, as an example, if a physician tells them you have atrial fibrillation and they don't follow up either with medications or therapy such as ablation or any other problems, then they could end up with a stroke. So what's important, and who is the patient who should have an ablation? Number one is those symptomatic patients who failed antiarrhythmic therapy at least once by the guidelines from the American Heart Association or from Heart Rhythm Society, or those individuals who are not able to tolerate medications for any reason. Atrial fibrillation ablation has now become one of the choices in the categories for the treatment of atrial fibrillation. What I'm trying to say is it used to be just medical therapy and that's all we had. Now we can actually attempt to cure these arrhythmias in order to provide the patient with a better quality of life. If you have any questions, please don't hesitate to contact me or contact my office at 818-718-1600. Thank you.